Let's see. All right. Hey, everyone. Um, Welcome to the PPCL Pediatric Mental Health Tele-Echo. It's 12 o'clock, so we're going to go ahead and get started. Thank you so much for joining us today. This is our 5th session. My name is Jody West, and I am the coordinator for the Echo. I want to go over a few housekeeping items before we get started or before we begin the presentation. Like I've asked, please, and if you have already, thank you. But if you haven't already, enter your name, title, and organization, as well as an email address in the chat box for attendance. If we've emailed you before, we already have it. It's just for our new guests that have joined us today. This is our agenda. We'll do our best to adhere to this schedule. It does go by pretty quickly, especially when we get into discussion. So we're going to move through it pretty quickly. Dr. Olivier is going to lead us into introductions and then pass to Dr. Cocky, who's going to present our case. After she presents, we'll open the floor for clarifying questions from our participants and as well as the hub team. Once those questions have been answered, we'll transition to providing recommendations. The recommendations will be sent to Dr. Cocky, so Dr. Cocky don't have to worry about taking too many notes. After the recommendations are presented, then we'll switch to Dr. Freeberg, who is going to present our didactic today. And then we'll wrap up with announcements and close our session. So I'm going to pass to Dr. Olivier to lead us in introductions, please.
So good morning, everybody. I'm Dr. Olivier. I'm a child and adolescent psychiatrist here in Lafayette, Louisiana. I own the private practice here, Bloom Mental Wellness, and I'm the facilitator for this Echo session. So I will be making sure that we stay on time. I'm going to we'll go around and introduce the hub team. We have a number of participants today, so we'll just introduce the hub team, and then we can move into the case presentation. So you already met Jody West, who is our coordinator. How about Lena? You want to introduce yourself?
Yeah, sure. Good. Hi, everybody. My name's Lena Reggett. I'm an LCSW, also on the hub team. So here to support and provide any technical assistance that folks may need.
How about Lisa?
Hi, I'm Lisa Spence. I am a pediatric nurse practitioner that does primary care and behavioral health care at St. Bernard Community Health Center, and I'm part of the hub team.
And Dr. Queen.
Hi, I'm Dr. Queen. I'm a pediatrician and I practice in Bogalusa, Louisiana, where I see a lot of behavioral health, and I'm here as faculty to help support any pediatric questions.
Thank you. And thank you all for coming today. I saw we have pediatricians, we have a lot of social workers, we have the family tree represented, LSU Family Medicine, United Healthcare. So welcome all of you, and please continue to put in your name, your email, and your organization in the chat box. Today's case presentation is being presented by Dr. Cocky. We're going to spend about 15 minutes on the case presentation, followed by 10 minutes of clarifying questions, and then 10 minutes of recommendations. And we always encourage our spoke participants to chime in first before kind of the hub team joins in. So, and then Dr. Freeberg is going to give us a case presentation, not a case presentation, a didactic at the end. To the didactic presentation from Dr. Freeberg. I love when the didactic coincides with the case too. So he's going to talk to us about diagnosing autism. Hey, Dr. Friedberg, you're muted.
That was a really bad start. I'm a psychologist. I've been a psychologist for about 30 years. I did include my email address on there. For anybody that wants to email me and talk to me about any issues and things like that, I'd be happy to talk to you individually or call you. In the last 10 years or so, when I think this is kind of coincides with some of these other things where insurance companies started requiring the ADOS. And so I went through the process about that time to get more training in the ADOS and became much more interested in autism. Obviously, I've diagnosed it throughout my career, but it became a lot more knowledgeable about what I was looking for that were much more subtle things. You know, I mentioned earlier about I don't need the ADOS on about 80% of the cases that come in. It's much more obvious, but the ADOS has been a tool that has really opened my eyes to looking at a lot of other things that kids present with, especially at an early age. And so I'm much more comfortable, much more confident trying to split hairs with those cases that were much more difficult, say 10 years ago. And I've really spent my last 5 or 6 years with any opportunity for CEs. I have to have CEs every year. And so anything I can find about autism, I've really tried to spend it doing that. And so um, I do, obviously, we're talking about a bottleneck of really evaluations for kids with Medicaid. And so, I'm here to talk about trying to identify kids earlier to try to get them into ABA and services earlier, which is still going to have that bottleneck with Medicaid kids, which is unfortunate. But I am interested in talking with some of the pediatricians about maybe things that could be done in their office, whether it's about incorporating the ADOS and other things like that. So that may be something that's kind of a side discussion. So um, let's start with, I really am trying to focus on early kids, early age kids, 1 to 3, 2 to 4, those ages. I really think that is the best time for us to try to pick up on the things that are already starting to go wrong. The case example by Dr. Kaki is kind of a perfect age to me for us to be taking a deep dive and look at this child that she's talking about. And I do some occasional pro bono things, and I would be happy to look at that child for Dr. Kaki. So, but these are kind of classic signs that parents, I think, often report. We obviously hear about eye contact issues, kids that are hand flapping or arm flapping. Um, you hear about kids that are hard to snuggle or cuddle or hug. They don't like to be touched, things like that. Um, Socialization, when I have kids come in here that are 2 or 3 years old, sometimes they'll come into the office. I've got both of their parents there. Um, we'll sit and talk for the whole hour. The child does not, you know, turn around, doesn't look up, doesn't share things or show things to us. They're kind of in their own world, and it's pretty obvious there that they're not in tune at all. They're not socially aware of what's going on around them. Um, Obviously, speech and language delays. Sometimes it's just speech and language. Um, if we don't see other things, whether it's the socialization issues or repetitive behaviors and things like that, then it may just be speech and language issues. Kids that are spinning or doing kind of sensory, full body sensory things. Um, Food aversions, I'm sure you get complaints like that as a pediatricians a lot, or as primary care physicians a lot, about kids only eating chicken nuggets or only eating the 3 or 4 things that they typically eat. Um, we talk about functional play with toys. I have children that come in on our first visit, and they'll have touched every toy in my office, but they won't have played with any of them in any kind of functional way. They're more dumping or rearranging or organizing or color coding or doing things like that. Um, we talk about kids looking at things from an unusual angle, whether it's kind of out of the side of their eye. They may hold things up and look out at the side of their eye. Obviously, kids, classic kind of signs are looking at wheels a lot, getting down at certain angles and looking at things at unusual angles that we see. Obviously, not orienting to their name being called. Whether it's, when I call kids names in my office, I start with a regular tone, I change it up. I try to get them to look, and see how long it takes to get attention. Um, we obviously hear about kids lining up toys, sorting toys, things like that. I definitely get children in here that I call dumpers. They dump everything out. They don't really play with anything once it's dumped out. Sometimes it's just dumped out and put back in, and dumped out and put back in, and um, that can just kind of go on, and it's not very functional. I mean, they have an idea about what they're doing, but it doesn't make much sense to the rest of us. So um, the other things that parents often don't report slide. Um, I definitely have about a third of the kids that I see who, and I don't know, maybe you guys can tell me, but there seems to be a pause or regression in their speech or use of words. It's usually between the ages of 1 and 2. And I had somebody come in recently who this happened with, and she was convinced that it was the vaccines that did it, and so she didn't vaccinate her next child. But this is something where parents say the child goes quiet for a while, so they use some words and then they stop using those words. And this sounds like it goes on for about 6 months or so, and then some progression starts again. Um, repetitive play. So, we talked about if kids come in and there's just speech issues, um, I want to see if they are doing anything kind of nonsensically repetitive. Um, we talk about restricted and repetitive play with kids. And so that can be anything from wanting to do the same things over and over again to just a very narrow range of interests. And, that can be something that we see or something that the parents report. I do find a lot of the kids, and this is a question I often ask, which is their sensitivity to pain. Most kids, if they do have a sensitivity, it's an undersensitivity to pain. They'll be bruised, that the parents say they don't know how they got bruised, or they could have a ruptured eardrum that they didn't complain about. Those kinds of things. You know, it's probably, I see that with at least half or 2/3 of the kids, that they seem to have real sensitivities to those kinds of things. Um, Often, talk about kids being really more focused on objects instead of people. And so, I don't know what, in terms of your exam rooms and other places that you try to look at kids for these difficulties, are there opportunities for them to play with things and see things? And, how much are they focused on the things versus how much are they focused on the people? And again, that gets back to, if they do like some things, are they showing them to you? Are they giving them to you? Do they want to show you what they're doing? Obviously, little kids usually want tons of attention. They want your attention all the time. Anytime they do something, they want you to see it. That's what's lacking with kids on the autism spectrum disorder. They may do a little bit of those things, but it's often um, way short of what they should do for their age. Um, Becoming hyper fixated on toys um, or things. Usually with this age child, it's toys. They can be. One of the things I say to parents is that if kids are not responding to their name or they do it inconsistently, sometimes they can really hyperfixate on something, and often they're trying to figure out how something works. Um, if they're really into what that is and figuring it out, they really don't hear you very well. Um, Sometimes you can catch them in between these objects and call their name and they turn, and it's because they're not really drilled down on those things. I try to put a positive spin on some of that with parents to let them know that, if they're spending a lot of time trying to figure this thing out, they're going to know a lot about how things work. And that's going to be a strength for them as time goes on. But they're doing it at the detriment of socialization. So they're not noticing people around them. They're not noticing what others are doing. They're not communicating kind of the way they should. Um, I often hear, this is mostly with a little bit older kids, but they'll say they get around other kids, but they just kind of watch them play. They don't really approach them, or if they do approach them, they're kind of not sure what to do or how it works. And so, um, you know, I hear that with even elementary age kids, 4, 5, 6-year-old kids. Um, they don't show or give things. I mentioned that earlier. I often find too, kids, if they've spread out a bunch of toys in my office, they will at some point just walk across the toys. I don't think that's typical. I think they're basically focused on something across the room or something on my desk. And they just make a beeline for it and they kind of walk across toys. And, not to say kids aren't going to step on toys at a time, but, usually if you start to walk on toys, you kind of look down and realize you're walking on toys and then you quit doing it or you step aside, but they just kind of walk across the toys. Um, I write this down a lot with the observations I have with kids in the first hour, that they can be verbalizing a lot throughout the hour, but a small percentage of it is towards their parents or towards me. Most of it is just directed out there or towards the toys. Some of it can be okay with, if they've got a few action figures and they're doing some dialogue or things like that. But a lot of it is just non-directed verbalizations that aren't really towards anyone. They're just kind of talking. Um, Climbing on caregivers instead of really hugging or snuggling with them. Sometimes they say, "Oh yeah, he loves to get on me," and you think, well, that's a good positive thing, showing some emotion, but then you realize they're just kind of crawling on them like an object, and not really like, a person that you would kind of do that way. And I see that a little bit with kids that violate personal space. Some kids will come and sit, on my chair the first time they come in, which is not, typical. They don't know me. Um, those kinds of things where it's just kind of not typical kind of personal space things. Obviously, finger and hand mannerisms. Sometimes parents don't notice these things, but any kind of, just stemming kinds of finger movements or hand movements that don't really have any function. Um, Kids seem to, we see a good portion of maybe 30-40% of the kids seem to have those kinds of mannerisms. A lot of kind of flitting toy to toy, and not really playing functionally. Again, I had a child in here this morning that was about 5 or 6. And again, when they come in at 5 or 6, I always feel like they're late to come in. But at 5 or 6, kind of, toy to toy, not really, can't sit for a movie, can't watch things for very long, wants to kind of move on very quickly to the next thing. And, some of that can be, I know you mentioned, are there other things going on? Of course, there can always be other things going on with attention or focus or kids with obsessive behaviors that can mimic some of these restricted and repetitive behaviors. And so that's definitely one of the things that we have to kind of rule out. There are definitely kids who have kind of obsessive compulsive behaviors that don't seem to have autism, even though they're demonstrating these behaviors at a very early age. And so usually in those cases, there's a parent or a history of anxiety or OCD in the family, and we're starting to see some of those kinds of behaviors. And there are times when it isn't autism. They are demonstrating some of those kinds of behaviors that sure look like it from that initial impression. Um, a few other things. I mentioned about the eye squinting. Kids squint a little bit when they're looking at things, or we talked about looking out of the corner of the eyes at things. Um, they seem to often climb, endanger themselves. Parents describe them as fearless. Um, they'll often run off. And so, they kind of just, I call it eloping more than anything else. And then the last kind of thing that I wrote down here on my notes was just kids walking on their toes some. And obviously, I know people who walk on their toes who don't have autism. But when I see kids who have a lot of the other symptoms, and that's just another one. Each and every one of these things obviously is not diagnostic of anything. I have plenty of kids that come in whose eye contact is really pretty good. And, I think there's beliefs out there by some that if kids make good eye contact, they don't have autism. Um, and that's not the case. Some kids have been taught, by the time they get to me, whether they're 4 or 5 or 6 or 7 or 8, um, to make pretty good eye contact. But it wasn't something that they did naturally. It wasn't something that kind of came rolling out as their development came along. Um, the other, so just, we've talked about the ADOS a lot today. The other things that I do when kids come in is I do spend the first hour with the parents and the child in my office with a lot of different toys. And that's an opportunity to get kind of social history and developmental history, and then kind of let the child play and warm up and see what they're interested in, how they play. There'll times when I'll get and play with them and interfere with their play and um, call their name and do things like that. Most of what I'm looking at with their developmental history is language, social, and play, as well as kind of that restricted and repetitive behavior. I usually spend that first hour with the parents. Like I said earlier, about 80% of the time, I know that the child has autism by the end of that first hour. Um, we're looking at, in terms of norm reference, I know you guys talked about maybe some screeners and things like that. I usually give a behavior rating scale to kind of rule out some other things, as well as, looking at social issues and things like that. If they're in daycare, that's very helpful to me so that I can see how they're interacting with other kids. I will say, that sometimes parents come in and say the daycare has no problems with them. And of course, I'm like, well, that's interesting. But, when you probe more, it's because they play by themselves and they don't bother anybody. And so the daycare doesn't have a complaint about them. But, when pressed, when they have to fill out these forms about what the child does and how much they socially interact, then it's very obvious that they're not doing the kind of social things that they should be doing. They may be parallel playing, they're not interactive playing, they're doing their own thing. And, at daycare, a lot of the places, if they're doing their own thing and they're not bothering anybody, then, that's good enough. The social responsiveness scale is the thing I was talking about. That is filled out by parents and teachers if we can get it, or caregivers if we can get it. It asks all questions about social behavior and restricted and repetitive behavior. I really like this instrument a lot. It's something that, it's easy to use, easy to score. I think that it's correlates very highly with what I get with the ADOS. In other words, it's just another. I mean, there are times when I get differences between the two, and then I have to try to make some decisions about what's what. But it is a good scale, and it usually gives me a lot of good information. And then the ADOS, we've talked about a lot about it today, and it's kind of a play-based test, and some of the things are kind of like what I do in the first session. There's lots of toys and things like that, but we're trying to elicit different opportunities for different responses from the child. Gives us another hour, gives us opportunities for play. We do certain things we call presses in the evaluation, which is for young children, we may when they're playing, we block their play, we stick our hand in the way, we see how they react to it. Typically if somebody blocks your play, you should kind of look up at them like, what are you doing to me? What are you, some kids will kind of just push the hand away. Some kids will just get up and walk off. Kind of like, well, there's nothing I can do about that. So there's, we have bubbles, we have a lot of exciting, fun toys. And a lot of it is, again, looking at how they socially respond, not just to us, but to their parents who are sitting in the room. Do they bring them things? Do they show them things? Do they check in with them visually, like kids should be doing? Do they try to get their attention? And so I'm watching a lot when we do the ADOS about kind of where their eyes are and where their eyes are going. We're looking for them to demonstrate joint attention. For those of you that don't know joint attention is that, I get your attention because I want you to look at something with me. So planes flying in the sky, I say, hey, look up at the plane. I point up to the plane. We look at it together. That's joint attention. And so kids on the autism spectrum have a lot of difficulty with those kinds of things. They don't initiate joint attention. They often have trouble following joint attention. We have a scoring system at the end of the ADOS. So once the parents leave, we sit down and score. It's got normative-based scoring system that we can compare to other kids their age. The interesting thing and also the hard thing, because I'm listening to the possibility of people giving the ADOS, once you've given 100 or so, it's easy, but the first 100 are hard. There's 5 modules, and each module is different based upon the child's age and their language level. And so we have a toddler module. We have a module 1, which is usually kind of 2 and 3-year-old kids, 3-4-year-old kids. And then a module 2, which is kind of 6 to 10 type thing. And then module 3 is for older kids. And module 4 goes up into adults. And I've had the interesting, just off topic, but, I do have a lot of people now that come in their teens and early 20s wanting to know if they have autism. And so some of it is because of TikTok and other things like that. Sometimes they are actually correct that they do have autism. and sometimes they have something else. But it has been, it is interesting, and it also gives me some insight into these older kids and what they're like looking back. If I can get a history of them looking back, about what it seemed like when they were in elementary school and middle school and high school, it can give me a better understanding. Um,
Dr. Freeberg, we're short on time. Sorry to interrupt you.
Go ahead.
Good stuff, though.
All right, I think we're at the end, weren't we? Yes. So I did look at the MChat that I know a lot of you use, and I think it's a good screening instrument. I don't know how much it's used, with every case, but it looks like it's a very good instrument. Obviously, I don't like the wait and see approach with 2 and 3-year-olds. I see too many 5 and 6-year-olds, and it's too late to kind of intervene with kids and get them into ABA and get them on a waiting list. So I guess I would just encourage as much as we can to get 2 and 3-year-old kids there. I'd be happy to answer questions or to even have any kind of discussion. I'll hang around after this is done.
Thank you.
Thank you, Dr. Freeberg, and thanks to Dr. Kaki for presenting the cases. We appreciate everyone's questions. We are putting the survey in the chat for anyone to do if you are interested in CEUs. Our next session will be October 10th. And the focus is on binge eating disorder evaluation and management. So thank you everyone for your time. We will post the recording to the website once we get it edited, and we will stay on online in case anyone wants to ask Dr. Freeberg any questions. But thank you everyone for participating, and we'll see you on October 10th.